All right, guys, this lecture is going to be about sedatives, hypnotics, and we're also going to talk about alcohol. It seems like it's a lot of slides, but don't worry too much. The alcohol part is quite a few slides that I threw in there, and a lot of it's not necessarily all that relevant as far as testable material. It's more kind of just interesting things. So when we talk about sedative hypnotics, street term here would be downers, and really we're using a lot of drugs that are kind of similar if you look at the pharmacology, but they're used for all types of different indications. So the primary things we're going to be talking about are going to be anxiety, anxiolytics, sleep medications. So sleep medication would be like a hypnotic, anti-epileptic medications, so benzodiazepines specifically, and some other ones, and just general sedation. So that could be a use for some of these meds too. So again, you usually maybe have like a sedation effect. Which can have some sort of a calming or anxiolytic effect, depending on what you want it to accomplish. So those are kind of two areas where the drug works. And then the third would be hypnosis, which is inducing sleep. These medications are really common. A lot of people take them for a ton of different reasons. Whether they're appropriate or not is a good question. But whenever you see, we're going to talk a lot about benzodiazepines, and I think whenever you see a benzodiazepine on somebody's medication list, if you're doing primary care or whatever you're doing, I'd always just think twice about whether it's indicated or whether it's actually appropriate for what the person's taking it for. Because I do think they're quite overused. I think there's a lot of other medications that fulfill their need, but don't necessarily cause, aren't habit forming and don't have as severe side effects. But because they do have sort of an inhibitory effect to them, they are very commonly abused, and a lot of people do overdose on them too. And overdoses can usually by themselves aren't fatal, but usually they're combined with other things like alcohol and maybe opioids. And you end up with a really nasty overdose. I've got Heath Ledger as the Joker here. He was sort of notoriously overdosed on a combination of he had multiple benzodiazepines in his system, and he had alcohol, and I think maybe some opiates too. So again, usually you're looking at combination overdoses are going to be the most problematic when you're thinking about sedative hypnotic overdoses. Okay, so our benzodiazepines, we've talked about these a lot off and on here and there, and finally we're going to get into some more detail on them. So these are a controlled substance, as you can probably imagine. They're Schedule 4, so it's actually pretty low on the tier of controlled substance, but they still are really highly abused. So they're something that you should think twice about prescribing, but there are definitely good uses for them. So we'll walk through some of those here in a minute. Benzos have sort of a spectrum of activity depending on what agent you're talking about. So some of them are maybe much more sedating and don't really have much of a role in anxiety, and other ones might have a minimal sedative component but have a bigger anxiolytic component. And when we talk about these, it's important to remember those subtle differences, and I'll kind of point them out here. The medications work really quickly, so no matter what you're trying to treat, and whether you give it oral, a lot of them come IV too, so that, or IV, IM, those can of course work quite quickly. An oral onset is usually pretty fast too. You have a difference between medications like these that actually would stop a panic attack or an anxiety attack right away versus like an antidepressant that takes a few weeks to actually see some results with. Because of their instant ability to cause sort of an inhibitory response, maybe produce a little bit of euphoria, some people do get a bit of a physical dependence to them, or maybe they become dependent on the effects they cause. They feel like they can't function unless they take them. Some people take them daily for sleep, which I wouldn't recommend either. But anyway, they can cause addiction in the long term. But other than that, medications actually have very few side effects if you separate them from what they're actually doing, right? So they're going to be sedatives, so they're going to cause sedation. They might cause a little bit of altered mental status because that's really what they're doing. They're inhibiting. They might cause some cognitive decline temporarily, so you might have some psychomotor slowing, and that's not uncommon either with them. But that's really the purpose of them. That's what they're doing. So I don't necessarily count those as side effects per se. As far as if you separate those out, meds are not going to have a lot of side effects per se. So you aren't going to, it's not like they're anticholinergic or really, but we'll talk about some other little nuances with benzos and some things to watch out for. So what do they do? Well, we've talked about GABA a little bit. So GABA, or gamma aminobutyric acid, is a a neurotransmitter that basically helps with inhibitory processes through the body. So when you give somebody a benzodiazepine, you have these receptors in the central nervous system, and here's your synaptic cleft. So these are like on one side of the synapse, and they're chloride channels. And so what's going to happen is that when these chloride channels open, that's just the natural response. So GABA is a natural neurotransmitter that you have in your body, and when your body activates it, these receptors, you get a relaxation sort of the excitatory complexes within the central nervous system, leading to an inhibitory response. What benzodiazepines do is there's a site actually that's been identified as the benzodiazepine binding site on this receptor. So it's kind of interesting that these drugs we're making actually have a binding site named after them, because that's really where they work. And what they do is by binding to this site, they can actually make GABA a little bit more effective. So maybe it binds GABA at a higher rate or more frequently than it would other times. So essentially, you're just potentiating the effects of GABA. And if you do that in a potent enough way, you can really create a really strong inhibitory response in the central nervous system. So that's pretty much what I talked about. I think it just outlines it here in writing in case you want to refer back to it. These are the primary benzodiazepines, and I'm going to point out some of the differences. I'm not too concerned obviously I'm not concerned doses, but this is a nice thing to look at. If you're ever working with patients and benzo dose equivalents can be a little bit tricky, but this chart might help you out. You can see that some of them are really similar. So like lorazepam and alprazolam, the dose ranges are quite similar. Whereas oxazepam, it's totally different. Chlordiazepoxide and diazepam are different as well. But generally, you don't go between them all that much. But if you did, you know generally what you're looking at here. As far as metabolism, there's a number of things on here which we'll talk about here in a second. Half-lives are really important too. So that's going to dictate a lot of what the differences why we're prescribing certain ones. So like benzodiazepine, like lorazepam, oxazepam, and alprazolam are all pretty short-acting, whereas chlordiazepoxide and diazepam are really long-acting. Clorazepate we really don't use anymore, so we'll kind of skip that. But these two medications have a lot of active metabolites, which makes their half-life so long. So that's why you're seeing that with those. So there's some advantages to that, and we'll talk about that in a little bit here. Okay, so we talked about side effects. So short-term low doses, sedation, maybe coordination issues, euphoria. Those are kind of just come with the nature of what you're trying to treat and what you're using. High doses, if you got like a mild overdose on a benzodiazepine, you're going to be looking at some more aggressive symptoms, so paranoia, aggression. So remember, benzodiazepines, we don't necessarily like to use them by themselves for people who are agitated or aggressive, or demented patients or people with Alzheimer's who have some sort of psychosis element, because they do cause this paradoxic aggression, irritability. And that happens much more so in elderly patients. So we try not to use them for that reason, because they do kind of have that effect, which we wouldn't necessarily expect, but you do see it. Long-term use, there isn't a whole lot other than the tolerance issues. So you have one thing to consider would be that you have tolerance, so physical dependence comes. So you might have more and more dose you need to get to the same effect. Long-term use, if you stop or decrease your dose, you can end up with rebound anxiety. And over time, they've seen that the longer you use a benzodiazepine, generally the less effective it actually is. And then there's the withdrawal risk. So withdrawal, I think I probably have another slide on here, but seizures are the major thing. So withdrawal seizures can be fatal. And so benzodiazepine withdrawal can be deadly, and it is something we take very seriously. So if somebody's on a chronic benzodiazepine regimen, we want to be really careful with stopping them or trying to reverse their benzodiazepine. You just want to avoid that seizure situation if you can. If you do overdose on a benzodiazepine, and by that I mean you take a lot of it, heavy sedation is common. That's pretty much all you'll see. Respiratory depression is usually mild. So I said that you can't really, they aren't as dangerous an overdose as like an opioid, where the respiratory depression will eventually kill somebody. In this case, you have a debate. I think you have some people who think that you can get enough to be fatal, but I think in literature usually fatalities related to benzodiazepine overdoses are related to co-ingestions too. So certainly there's a synergistic effect. Like if you took opioids and benzos, you might get more respiratory depression than you would if you just took the benzo or the opioid by itself. But by themselves, on their own, it's very difficult. Sometimes people might get such shallow breathing where they have to be intubated, but usually people aren't dying from an opioid or from, a benzodiazepine overdose by itself. Just heavy sedation is probably what you're going to experience. Now, that depends on a lot of things. You could take a ton of it, and maybe if you take enough, it does do that. If you take a really long-acting medication and it's in your system for a while, that could maybe cause some concern too. With respect to metabolic concerns, so I showed you that other slide, but what I'd really want you to remember is LOT drugs. So LOT stands for lorazepam, oxazepam, and temazepam. And these three drugs don't have any active metabolites and really no drug interactions, and they aren't renally dose adjusted at all. So if you have somebody who's got renal issues and you want to treat them, a medication like diazepam has a lot of active metabolites and a lot of renally eliminated active metabolites. So it can be problematic because you're going to accumulate those, and that drug already has a really long half-life. And a medication like lorazepam would accomplish pretty much the same things as diazepam would, and you don't have to worry about any of that. So that's just an acronym to maybe keep in your back pocket, that those drugs don't have the same metabolic concerns that like a diazepam would. So it's a little bit more convenient that way. Okay, so looking at anxiety as one of the core components. So when it comes to anxiety disorders, we talked about how SSRIs are pretty much first line, and we treat it very similar to we do depression. The one big difference is you have the ability to give somebody something short-acting that will work in the instance that they have a panic attack. And that can be a really nice tool to give a patient before they have the time taken for like an SSRI to actually kick in. When you're looking at benzos for anxiety, one of the things you want to consider is sedation. So alprazolam or Xanax is really popular for that reason, because it is probably the least sedating out of all the benzodiazepines. Clonazepam or Klonopin is pretty good too. I would say both those top two are the two you should probably think of most when you think about treating somebody for anxiety. Not that lorazepam and diazepam aren't indicated, but the nice thing about Xanax and Klonopin are that you have a short-acting benzodiazepine, so you should be able to accomplish your goal without totally sedating the person for an entire day. Whereas if you gave somebody a Valium, that could last quite a while. You also have Ativan, which is kind of in the middle. Ativan's a bit more sedating than the first two, so I'd think of it more as a third-line option. I would prefer, if you're going to treat somebody who's out and about in the general public and they're taking an SSRI for the anxiety, but they might have an occasional panic attack and they need a short-acting benzodiazepine for that. Alprazolam and clonazepam are probably going to be the two ones you'd prefer to have somebody on. Now, I still wouldn't recommend somebody take one and get in a car and drive, but I do think that they're going to allow you to function better and be less sedated in real life than in real life. I mean, like in your day-to-day life, then if you're taking them at home or something, that's I guess a different story. But if you're at work or have something going on, one thing I would caution you as well is be really careful how you recommend people using these. Like if somebody gets really nervous for a job interview and you prescribe them benzodiazepines to take, it's probably not a great idea, because if they need to function cognitively, these can be really problematic, and they can actually kind of slow down the cognitive processing a little bit, enough so that the patient might not be functioning at their top. So just consider like if they're giving a speech or something like that, think about things where they actually need to perform. Benzodiazepines are probably not the drug you want to give. If they're having a debilitating panic attack about something and it's sort of like that or nothing, then sure, give them, but just remember to keep into context what you're trying to treat. Don't use a benzo for something that's performance related, that's like a performance related type of a thing. They're actually going to, if it detrimentally affects their performance, that could have a big impact on their life. So we need to take that into consideration and be really careful how you recommend people use these medications, because most people will find them sedating and find that they just can't, even if they're the non-sedating ones or less sedating ones like alprazolam and clonazepam, they just might not be able to process things as quickly. I think about benzos, and to be honest, I've never taken one, so I guess I can't say this for sure. But based on the pharmacology and based on like the side effect profile, they're very similar to alcohol in how they disinhibit the body and how people might feel. So think about that way. Would you want somebody to per se feel like they're maybe a little bit drunk before they would do something? That's something you might think about, because that could be a side effect of taking the benzos. It's disinhibitory complex. You feel a little bit euphoric, a little bit sedated. It's a similar concept, and alcohol actually pharmacologically has a lot of similarities in how it affects the GABA receptors to benzos. That's why I bring up those two comparisons there. So again, we can use them as bridging therapy. Commonly, they're used as needed for panic attacks. These should never be given scheduled for anyone for any reason that I can think of. Every once in a while, you see people who get they might get some prescribed as needed for panic attacks, and they start taking them daily, and then all of a sudden they're on a few milligrams 3 times a day of some sort of benzodiazepine. You're like, how did this happen? In that case, you don't want to stop the person, but you do want to figure out a plan to get them off of it, because it's just not going to be good long term. And if they happen to run out of refills, miss a few doses after they've been on scheduled for a while, then that puts them at risk for a withdrawal seizure. So in that case, as needed is really going to be the key here. And if you're going to prescribe these medications for panic attacks, make sure you're making that abundantly clear, because it's not only good for your patient, but you also want to protect your license. You don't want to be prescribing somebody, tons of benzodiazepines for a reason that's not, not a medically indicated purpose, which there are very few to give scheduled benzodiazepines to somebody for. All right, so if you have a choice, alprazolam, I think I would say, I don't know what I was thinking here. I changed this to clonazepam as a preferred agent. I just think lorazepam, while it's fine and people use it for that, I think that it makes more sense in a lot of cases for people to take that as sort of a second line option. I would try these two first, because you're going to get better results and less sedation with them. Some people do take them as sleep aids. I think it's more associated with people who have a anxiety component at bedtime. Maybe they for whatever reason they can't sleep, so it shouldn't necessarily be sedating per se, but it might help take the anxiety out of their bedtime schedule, and then that helps them actually get to sleep naturally. If you want to give somebody a bit more of a sedative, then lorazepam actually might be a better option for those patients. Driving and operating machinery, I would take it as seriously as you would alcohol. So I would prefer that people just wouldn't drive at all taking these medications. But you really have to be able to know, as a patient, you have to be able to know how you're going to respond to it. So the first dose should always be in a controlled environment. Take it at home, know how you're going to feel, and then you could go from there potentially. Cognitive impairment, and again, we talked about this already. So. All right, so what about using these as sleep? They are sedatives. There are a couple benzos that are preferred for sleep aid, and these really aren't used all that much anymore, especially triazolam. Temazepam or Restoril still actually probably does get some use. It's a long-acting benzodiazepine. It's not renally cleared, so remember, it's one of those lot drugs, so it could be where I do see this prescribed a lot to older people, and I think it's maybe not the best option, but when we talk about sleep aids in older people, there aren't really any good options per se, so there's that to think about. But with temazepam, it's an option to consider. It's not really used for anxiety. It's very sedating, so I'll consider that just a sleep aid. Triazolam, similar. Halcyon's the brand name of that. This medication has an interesting history. Out of all the benzodiazepines, all of them technically can cause short-term memory loss. However, this one has probably the biggest, most notorious story with it. There was actually a case where a woman, I think, pleaded that she murdered her husband, and she pleaded that she was on triazolam at the time, and basically, I think she got off. I actually can't remember how it ended up working out, so I kind of ruined my own story there. But the point is that this medication has been associated with people who have used it as a justification for murder, potentially, and also associated with suicide, too. People committing suicide on it. So triazolam, for a while, I think, was actually removed from the market. It's still available, very, very rarely prescribed, though. I don't see it used very often at all. Now, when it comes to, we're going to talk about sleep drugs, I think on the next slide or soon here. So we'll get those in a second. Those are similar to benzodiazepines, but these two drugs would really be, as far as specific benzodiazepines used for sleep, but any benzodiazepine can technically be used for sleep. I see lorazepam used for sleep a lot. Whether that's totally appropriate or not is debatable in some cases, but it is used for that. All right. So the sleeper drugs, or sometimes called Z drugs, they don't structurally really resemble a benzodiazepine, but mechanistically they're very similar. They have more of a selective benzodiazepine receptor use. So while maybe like a drug like lorazepam has more of a broad spectrum approach and hits tons of benzodiazepine receptors on all types of different GABA mediated chloride channels all throughout the central nervous system. Well, these ones specifically target a few that seem to be sleep specific. And they're listed here. So there's zopiclone, zolpidem, and S-zopiclone. So you have Sonata, Ambien, and Lunesta. You've probably heard of Ambien for sure. Very common medication, very common brand name. As far as differences go, they're all essentially the same. They do really the same thing. Sonata is the shortest acting, so some people might not feel like they get a full night's sleep if they're really having insomnia on it. Ambien has probably been the most popular one. It's been generic for quite a while, so I think a lot of people have been using it because it's relatively cheap. And it's also got a controlled release form, and I'll show you kind of the difference with that in a second. Then you have Lunesta, which is the longest acting. I think Lunesta actually went recently generic. So, but it is probably still more expensive than the other two. As far as side effects go, you have sedation, sleep activities, which we'll get into with some funny jokes here in a second. So before I get into that, I want to show you the difference between Ambien and Ambien CR. So if you're like, why would I prescribe Ambien CR? Well, you probably shouldn't. Every once in a while I get patients who tell me that they have to have the CR. We actually don't stock it at the hospital, and we have a substitution policy that says we don't have to give it. So even if a physician or a PA orders it, we can say, nope, sorry, we're giving them regular Ambien. You don't really get a say in that. And if you want to fight somebody on that, you can, but it's a losing battle. So here's the kinetic differences. So here's your 10 milligrams of regular Ambien. You get a burst and then kind of like a not quite a steady peak and then a decline off as far as your blood concentrations. You can see that CR is pretty similar. Your area under the curve is more, and you're a bit more steady onset, but at the same time, your offset is really pretty similar. So does somebody really get a benefit taking CR? I don't know. I find it hard to believe anyone actually does, but there's that possibility potentially. But to be honest, I think it's kind of a waste of money. But you'll see people on it occasionally who say that they can't really take anything else. All right, these are my couple of funny jokes for the day. This is Ambien Walrus. I found this on the internet somewhere, so I definitely didn't make this up. But the point of these comics is to show you that, in a funny way, to remember that Ambien and in these types of medications, so Ambien is not the only one that causes these. All these Z drugs can, and benzodiazepines can cause this certainly too, as we talked about the example with triazolam. But people do things during their sleep that they don't remember. So sleepwalking and sleep talking is common, especially if you're prone to that before the Ambien. However, there's more dangerous things that people do, like sleep cooking, sleep eating, which you might not think about as dangerous, but if you wake up in the middle of the night and you cooked yourself some food on a stove, that would be kind of scary to think about, using a stove in your sleep. There's sleep driving reports too, and it's all kind of lumped together as these sleep behaviors that people do, and they don't really remember. So here's some examples. This guy says, well, Ambien Walrus, I guess I can't eat all the cookies in a 3-pound family pack. Myth busted, let's go for a drive. So this is just a joke highlighting that people eat. Sleep eating is actually kind of a commonly reported thing. And so people will say they wake up with a plate of food empty next to their bed, or they come down to their kitchen and it was clear somebody was down there eating or cooking and they don't remember anything. All right, so losing stuff, using your phone, doing stuff like that, you get the point. I'll get over Ambien Walrus here. You can look them up. I think there's some more not necessarily appropriate for school ones that are on the internet somewhere that I found, if you're interested. Anyway, so as far as sleep goes, since we're kind of on that train of thought, I just wanted to talk about, because we've talked about a few of these, but I just want to talk about other ones people take for sleep too. You have antidepressants, so trazodone, mirtazapine, and tricyclics are all used for sleep, which we talked about. These are probably going to be your first line. So most people are going to take trazodone as a first line. Mirtazapine is also a good one. Benadryl or diphenhydramine I don't necessarily recommend because it's so anticholinergic. However, it's over the counter, so a lot of people are going to say, well, I'll just try it and see if it works. It's certainly fine for most people, but there's probably better options out there, to be honest, or more better tolerated. But every once in a while, you'll get like an 85-year-old person, and they take Tylenol PM every night before they go to bed, and they have no reported problems. So, what do I know? Melatonin, we haven't talked about melatonin as a supplement, really, and I kind of skipped over it. And this is all I'm going to really say about it, but tons of people take melatonin. There's lots of different doses and forms out there available. Every time you read about like some natural remedy that's like a sleep spray or something like that, it probably has melatonin in it. The studies on melatonin are mixed. I think a lot of people take it, but not everyone really reports very good results, if any results with it. There's a prescription product called Romeltian or Rosarem, which is a melatonin receptor agonist, which is supposed to be basically thinking of the melatonin concept with longer duration, more potent action. Now, melatonin in itself regulates sleep cycle. So the idea is that maybe if you have if you work odd shifts, like if you do night shift or you're switching work shifts, or if you're like an airline pilot where you're going on to tons of different time zones in a short period of time, melatonin can actually help regulate your sleep cycle a little bit better. But as far as the average person just taking it, it's not a sedative, but I have heard people say that they take it and they feel sedated afterwards. So I don't know. Again, what do I really know about melatonin? I can just tell you that the studies are mixed and not great supporting that it actually helps. There's a new agent out there called suvorexant or Belsomra. Belsomra, I threw it in here too because it just really doesn't have it's kind of its own class. It's an orexin receptor antagonist. Orexin is a neuropeptide signaling system that promotes wakefulness. So if you think about it this way, let's look at our sleeper drugs like Ambien. Ambien basically is a sedative when all is said and done. It works on specific GABA receptors that causes sedation. So it puts you to sleep. Orexin drugs like this one, which is the only one on the market for now, keeps you from waking up because what it's doing is you have a signaling system in your brain that promotes wakefulness, and this is shutting that down. So instead of making you feel sedated, it's actually keeping you from waking up. So some interesting pharmacology there. But really, they've seen that it tends to work similar to benzodiazepine from just a clinical observation perspective. People do have some similar behaviors too, like sleepwalking and stuff with these medications, with this medication, and also it's not recommended to combine them with a benzodiazepine-like drug, or so like a sleep drug, like a Z drug. So it's really just an additional option that people might be able to try. And there are lots of people that have issues with sleep and bad insomnia and have tried everything without success. So these are meant to give you some options, and this would be kind of a last line trial, but you could certainly give it a shot. And as far as the Z drugs go, they're pretty well tolerated for most people other than the sleepwalking side effects, and they are controlled substances, but I think they're like controlled 5s, so they're very low on the list. They might be 4s actually, I'm not sure, but anyway, they're controlled substances because people can certainly abuse them, but for the most part, I think they're used fairly appropriately, and people might be scared to get on them because they feel like they're relying on it for sleep, and that's certainly something that's valid, but I would recommend prescribing them as needed. If somebody starts taking it every night, that might be a question mark for you as a provider to say, well, is there something else we can try? Maybe something better that we can discuss as far as your sleep habits and sleep behavior. All right, benzodiazepines are highly useful for stopping seizures. So these are first line drugs for acute seizure activity. We don't use benzos for maintenance therapy unless very odd cases of people with really resistant seizures. But for the most part, these are just for acute phase. So lorazepam is the gold standard with benzodiazepine. And diazepam is also useful. Versed is another one that's used really commonly. So essentially all these are IV, and there's 3 reasons why you might use one or the other. So lorazepam is gold standard because it's the longest lasting. It's less lipophilic, which means that, and this is an important point, so pay attention if you're falling asleep so far. Lorazepam is less lipophilic, which means that it doesn't cross the blood-brain barrier as readily as a drug like diazepam, which is more lipophilic. So you might think, well, that's not good. We want it to get into the central nervous system quickly. And I would agree. But it's not that slow, but it does take like maybe a minute, 2 minutes to actually see some effect from it. Whereas diazepam is very fast. Now, the issue with diazepam is it's very fast, however, it gets out of the central nervous system as well. So what happens with diazepam, as opposed to lorazepam, is it crosses across that blood-brain barrier into the central nervous system very quickly. However, it also redistributes throughout the body, and so it will leave. So you get really high central nervous system concentrations that then taper off fairly quickly. So it works fast, but you can get a rebound seizure once that happens. Lorazepam, on the other hand, stays in the central nervous system more at a higher concentration for a longer period of time. So that's why it's preferred. Now, in an ideal world, could you give diazepam as your first drug to use it, quickly in seconds, and then switch to lorazepam? Certainly, but that's just not realistic in most situations. So where does midazolam come into play? Midazolam can be given IV, but there's also actually some really good data that shows that it works intranasally. So if somebody's having a seizure, especially a child or somebody with poor access, it tends to work really well for kids because the volumes you're giving kids and the doses you're giving kids are so low. There's only so much volume you can give in the nasal passages that's going to absorb. If you give too much, it's going to run down the throat and not going to be all that effective. Usually it's about 0.5 ml per nostril, maybe up to a full mil per nostril. So that's where you're looking at what type of dose you're going to give. And with kids, it's really helpful. And all we do is we withdraw the IV product and we screw this little, it's called a nasal anatomizer on there that creates a mist when you inject it, and that's all it is. It's just a sterile product from the IV vial, so it's really quick. EMS tend to carry midazolam a lot. Midazolam is a really versatile benzodiazepine because not only can it be used for seizures, it's also really effective as a short-term sedative for people who might be getting, an advanced airway, to keep them in sort of a medically induced coma. It's one of our popular agents for that. So midazolam or Versed has a lot of utility there. It's also a very good anti-seizure medication. So all these medications are good and will work, but I think in practice what you're going to see is midazolam and lorazepam being used most commonly. There's a product called Diastat, which looks like this. It's a rectal product that's made, and it's kind of interesting. It comes with a standard amount in it, but before it's dispensed, the pharmacist will actually lock in the dose. So the dose is prescribed to a certain point, depending on how big the child is. It's designed for pediatric use, and it's designed to be, again, administered rectally in acute emergencies. So this is to be carried by parents. So if your kid has a seizure, you can pull their pants down and put this in without having to give like an IV. Now, I would much prefer as a parent, if I had a kid with a seizure disorder, that I would be giving this as opposed to giving them something rectally. But this is a little more complicated for the average person to use. This is pretty easy. So you have some debate there. But, if you think about having a young adult child or a teenager, and you're in a mall and something pulling down their pants in the middle of the mall is not going to be the most ideal situation for sure. So that's where the nasal administration can be really handy. However, this is a really nice thing for people to have, especially if their kids are having frequent seizures. All right, alcohol withdrawal. We're going to talk about this at the end and show you this, but most hospitals will have a protocol that involves using benzodiazepines. We used lorazepam for ours for a long time, and we just switched to a new protocol called the MINDS protocol. We used to use CIWA. If you're curious, you can look at the differences. And again, I'll show a little bit more about this at the end. But diazepam is a bit longer acting, and where you're looking at alcohol withdrawal seizures, which is one of the biggest side effects of withdrawing from alcohol, that's going to be a nice benefit that it's long lasting and has those active metabolites that stick around. Also, when you're looking at alcohol disorders, the possibility for hepatic dysfunction is there. So you have to consider that somebody could be hepatically compromised with cirrhosis, and lorazepam might not get metabolized all that well, whereas diazepam doesn't doesn't have as much hepatic risk associated with it. Even though it does get metabolized by the liver, it seems to not really affect it all that much. So it might be a little bit safer for those patients with hepatic issues. Okay, elderly patients and benzodiazepines. Older adults are much more sensitive, and remember we talked about this during geriatrics. Medicare for a long time didn't even cover benzodiazepines, but now recently they have started covering some of them. The dose is probably a bigger concern than specific pharmacokinetics, so we really want to make sure we're giving low doses if you're going to use them. And overuse is a huge issue. And delirium dementia, this is, again, remember from the geriatrics component, one of the big three. So we think about opioids, benzodiazepines, and anticholinergics in older adults causing the biggest risk for delirium dementia. So just be careful with it. Withdrawal, I talked about this. Seizures at the very bottom being the most important thing. The rest of this is sort of, you can get rebound panic attacks, tachycardia, headaches maybe, but seizures would be the primary concern here for sure. You can reverse benzodiazepines in the case of an overdose. This is a controversial topic, and there's some really important things to remember about it. There's a drug called flumazenil or romazicon that's a competitive receptor antagonist. And if you're ever going to use it for any reason, just make sure you're starting with really low doses and working your way up. You can always give more, but once you knock those benzos off the receptors, then you can run into an issue that puts your patient at risk for a seizure. So when do we like to use this? Recovery from a short-term procedural sedation. If you gave somebody a little bit of midazolam to sedate them for a small procedure and they're a little bit overly sedated, this is a great drug to give them to get them out of that quickly. You aren't worried about a withdrawal seizure because they just haven't been on enough of the drug to make it matter. Small doses causing excess sedation. So maybe somebody was in your emergency department and they got, some Ativan because they were agitated, or maybe they're nauseous and they tried to use Ativan and it just was too much for the patient. They were really sedated. This can help bring them back a little bit about that. One-time overdoses is questionable. You can certainly consider it, and if you know for sure it's a one-time deal, but the problem is with an overdose, oftentimes you don't know that, and you're gambling maybe a little bit on whether they actually did take it one time, or maybe they're a chronic user. Maybe they've done this a lot. Maybe they've been taking benzos for the last week, and it's just finally accumulated enough where they've been called in, or they're so sedated they can't function anymore. That's dangerous. So just be careful. So chronic benzodiazepine users is something not to use this medication in, because that's your highest risk for precipitating a withdrawal seizure. And the other thing definitely not to use this in is hopefully common sense. But if you're treating somebody who came in with a seizure with a benzodiazepine and you give them, I've seen this happen a lot, where you're pushing a lot of Ativan into somebody and you aren't seeing a response, and all of a sudden it's like the person's totally zonked out. That can happen because, again, Ativan takes a little bit more time to get into the central nervous system. But the point is that you have a dangerous situation potentially if you were to give them something to reverse that because you overdid the benzo, and you can have another seizure. So the best thing to do in those situations is just to let the benzo ride, let it work its course. You're really going to overdose somebody, you have problematic consequences from a benzodiazepine overdose, and if that's the case, the seizure is the worst thing to happen than the benzo overdose. So that's your better of two evils, I guess, in that situation. All right, tapering and stopping benzodiazepines, lots of methods to do this. I'm not going to test you on these specifically, but just for the record, you can switch something. You can figure out your total daily dose, switch to, and then just taper down. That's a very simple way to do it. You can, if somebody is going to be admitted, so like let's say somebody has a significant substance abuse problem with mental illness, they're admitted, you can dose reduce them. So you can figure out how much they're taking a day, reduce the dose by 40%, and drop it by 10% each day. This is a hospital-only protocol. You wouldn't want to do this outpatient because you could risk putting somebody into seizure, which in the hospital setting, this is actually a studied method, so this is okay to do, but it is aggressive and it does have some risks with it. One thing we could consider doing is switching to a long-acting agent. In fact, sometimes if we get people who are alcoholics in our emergency department and might not necessarily have a reason to be admitted, sometimes I've seen our physicians maybe use a long-acting diazepam or Librium, which is chlordiazepoxide, to give them before they go, so they have something long-acting, so they aren't going to go into withdrawal right away. Carbamazepine and gabapentin may play some roles in helping, but there's not a lot of good evidence with that, or it's less so. Basically, you're looking at one of these strategies. Buspirone, I mentioned this briefly with depression. So it's not a benzodiazepine at all. It's actually a serotonin partial agonist and a dopamine antagonist in certain areas of the brain. It's indicated for generalized anxiety disorder. So SSRIs are still first line. So this would be something that you could maybe try as a separate one. It's a chronic medication. It's a serotonin medication. So think about it like an antidepressant kind of. It takes a few weeks to work. Unfortunately, it's usually dosed a few times a day. So either used for primary general anxiety disorder or for a depression, unipolar depression augmentation therapy. Okay, well, that was a lot. Let's talk about barbiturates really quickly. These are not common medications. They're essentially like think about them like a benzodiazepine, but much more potent, both in their effects and in their side effects. So there is a site for barbiturates on the same channel where the benzodiazepines bind to, and it just causes a more potent effect, basically. So sedative, hypnotic, and anticonvulsant properties, and you have a lot of adverse effects, including hypotension, bradycardia, and respiratory depression. So very narrow therapeutic index. When we talk about benzos being difficult to overdose on by themselves, these are not. You could get very significant respiratory depression and hypotension on these medications. So these could be fatal easily in an overdose. Clinical uses, sometimes sedation, preoperative sedation, seizures, not all that useful anymore, really, to be honest, just because our benzos are better. And phenobarb, I feel like sometimes they could use it sort of as a last line therapy for like a seizure. So somebody's having an acute seizure and you've tried Ativan, maybe you've tried some IV Keppra or something like that. You want something else, this could be an option potentially, but it's very rare to actually use phenobarbital. Every once in a while you see somebody on phenobarbital, maybe somebody who's taking it as an anti-epileptic drug chronically. Again, very unusual, but it is possible. Other barbiturates, there's a lot of different ones. Most of them are heavy sedatives, and they're usually used as very short-acting, high-potent things for either animal euthanasia or procedural sedation. Unusual that we aren't using these all that much, to be honest. So the one I did put on here, butalbital, is this very low-potency barbiturate that's used in combination with acetaminophen and caffeine as the migraine medication. So Fioricet is this drug. All right. Okay, so that's it for the major drugs. I want to talk a little bit about alcohol. Again, this isn't going to be very heavily testable material, but I do want to just discuss it. I think it's worth mentioning. We'll talk a little bit about some of the specific withdrawal protocols and some of the symptoms that you might see with alcohol withdrawal and alcohol abuse. So, of course, some fun facts here. We have history and background. So alcohol is probably the oldest, likely the oldest world's drug of abuse. It's kind of interesting. In fact, it's actually referenced very early in the Bible, in case you're curious there. And especially in American European cultures, access to alcohol, use of alcohol is very ubiquitous in society. It's very socially acceptable for people to drink moderate amounts of alcohol and even large amounts of alcohol in some situations. So it's kind of an interesting drug from that point, but certainly not without its risks. Some interesting stuff. A percentage of adults who binge drink. So apparently, if you remember my chart I showed you about people who are depressed, people who have the lowest rates of depression apparently are the heaviest binge drinkers. So remember, correlation certainly doesn't equal causation, but it's quite interesting because remember the South was also the highest depression, and they are the lowest drinkers too. So kind of an interesting side note there, but I think it's just funny to think about. In case you're looking at worldwide use, I don't think this surprises anyone that like Russia, France, UK, very high consumption rates. Of course, Middle Eastern countries or countries with predominantly Muslim populations are going to be much lower. And then the places that are more of a mix, like Canada, US, are going to be sort of in the middle. So nothing really too surprising there, hopefully. As far as chemistry goes, ethanol is the drug in alcoholic beverages. You guys all know this. Production is there. Usually when you're looking at an alcoholic beverage, it's important to think about the content in it. So if you're working with patients that have alcohol, if they have alcohol abuse disorders, they probably shouldn't really be drinking at all, but understanding just what's going on, what they're drinking. So usually 10 to 15% is about the ceiling. And again, this is kind of just fun fact stuff, but like, You can genetically engineer yeast strains like Sam Adams Utopias, if you've ever heard of that product. It gets up to 29%, and that's actually a beer. And then, of course, you have spirits, too, which are distilled where they're concentrated that way, and those have very high alcohol content, so 40, 50, 60% alcohol. But ultimately, it's pretty much all the same thing, just different concentrations and different flavors. The pharmacology, not really actually well understood. Again, we know that there's some activity on GABA receptors, but and similar to benzodiazepines. However, it's just a general CNS depressant. It has a lot of effects that we don't really know exactly what happens, and it's such a small molecule that who knows where it goes in the body and all that it does. It probably does a ton of things. Like NMDA receptor antagonism is a big theory behind some of alcohol's effects too, which in the inhibitory component of alcohol ingestion is likely I think that's a good explanation for it, to be honest. That's a fair assumption that it probably has some effect there. Increases dopamine levels too, so you get some euphoria. Has some, of course, addictive components to it. Is massive. Rapidly absorbed. Blood levels from consumption, you get max concentration about 30 to 90 minutes. It depends on how much you're eating, because that's going to depend on how active your GI tract is. So while food doesn't necessarily absorb alcohol per se, it will decrease the rate of absorption. So if you do a shot on an empty stomach, you're probably going to feel the alcohol a lot faster than if you do a shot on a full stomach. It's going to take a lot longer for that to get through your digestive system and to fully absorb. As far as the metabolism of alcohol goes, you have a couple different enzymes here. So you have ethanol gets metabolized to acetaldehyde via alcohol dehydrogenase, and then aldehyde dehydrogenase metabolizes that further into acetate. One of the problems is your body only has so much enzyme available, so it can only metabolize, a certain amount. This is sort of a rate-limiting step here. So if you use up all your aldehyde dehydrogenase, you end up with an accumulation of aldehyde, which can lead to some of the more unpleasant effects of alcohol consumption, such as nausea and vomiting, those types of things. And ethanol itself, just having a ton of it in your system, can do that, because your body's going to start sensing it as a toxin and want to get rid of it. And we'll talk about actually some unique mechanisms we can do when we talk about this summer. We'll talk about methanol poisoning and propylene glycol poisoning, and how alcohol actually, it's a similar metabolism pathway. And we'll talk about that. So it comes back into play. But for now, that's all you really need to know. Just some fun facts about hangovers. So basically, you get too much aldehyde dehydrogenase gets maxed out, and you get a buildup in this aldehyde, which is more toxic than the ethanol alone. So dehydration is also a big component of this. Alcohol inhibits antidiuretic hormone, so you get increased diuresis, so you get electrolyte imbalances as well. Immune system effects, not likely well understood. There's some research that shows that there's some enhancement of inflammatory cytokines. So that's possibly due to why people might get headaches or feel ill after drinking a lot. NSAIDs tend to be worked well, and people actually do study this stuff, so I'm not just making this up. And actually, there was a study I found that said that people actually looked at darker liquors causing worse hangovers. So interesting that there's, other chemicals. So if you're going to stick to something like vodka, which I personally think is nasty, but that statistically and studied has less of an effect of causing a hangover, if you want to believe that or not. Okay, so acute alcohol effects. I'm not going to test you on any of this stuff, so don't worry about it. But in case you're curious as to know sort of what people are going to experience and where they're going to be at, and this is just general, population. The thing is people who drink a lot are going to be really different. So somebody could present, a heavy drinker, 0.1 might be nothing to them. They might seem like they're totally fine, like they haven't had a drink in years. And they can really go much higher than somebody who's alcohol naive or only drinks rarely. But this is sort of what you're looking at. I mean, you can see, like, when you have vision impairment, that's when they start to get nervous, and that's why we have a legal limit for driving a vehicle. And then you have all these other things too. So again, this depends on the person. So 0.3 to 0.5, you might not have severe CNS depression. You might have somebody who's really agitated and annoying, but they aren't actually passing out. And 0.5, you can have above 0.5 too and not die. So there's just it depends on how used to alcohol your body is, and you can definitely see, if you work in an emergency department in a large metro area, you're going to see a lot of interesting really, really high alcohol contents. You're like, how are you functioning with that much alcohol in your system? But it's just it's a tolerance that they've built up over time. This is not really all that important, just in case you're curious about weight and what generally you'd be looking at as far as how much alcohol you have to consume to get to what blood levels. And then alcohol is a self-medication. There's no actual therapeutic benefit for taking alcohol. They talk about like antioxidants and stuff like that. Well, I can talk about that in a second. But basically, what do people are using this for? People are self-medicating with alcohol. People do, a nightcap or so to induce sleep. If it's effective, the thing to remember is that it's usually going to have a problematic side effect to it, which it doesn't result in physiologic sleep. So there's some evidence that shows that alcohol actually suppresses the REM cycle. So people who are using alcohol to take for sleep might actually not be getting as restful sleep as they would otherwise. Or if after a night of drinking, or even if you had like 1 or 2 drinks and you're feeling sleepy, you might not get as, even though you feel sedated, you just aren't going to get that same sleep like you would naturally. People do self-medicate for all kinds of mental illness, of course, and there's no upside to this. It's not going to happen. If somebody does feel better about it, it's going to be a temporary effect at best, and they're going to have to keep drinking to get that effect to be sustainable. And eventually, they're going to either end up not being able to function on a daily basis, or probably go into a withdrawal seizure or something like that when they don't have access to the alcohol. Again, self-medicating, not a good option here. Of course, consequences of acute intoxication are sometimes problematic for your bowels or your GI tract, problematic and maybe sometimes humorous, and then also absolutely devastating too with automobile accidents and such. So not necessarily a laughing matter, but sometimes there's certainly humorous aspects about it. All right, so what about chronic toxicity, and what do we do for it? GI tract can be damaged pretty severely, which can impair nutritional absorption, which is also kind of a double whammy because people who are chronic alcoholics usually aren't eating a lot of decent food, and whatever food they're consuming a lot of calories via alcohol, and they aren't getting a lot of nutrition otherwise. So that's a big issue there, and it's compounded by the fact that their GI tract is severely damaged as well. Liver, of course, being the biggest issue here. So people who drink over time are going to get cirrhosis, which is usually a function of having aldehyde build up over the time, which causes oxidative stress and hepatic cellular necrosis. And it is fatal if drinking is not stopped. If somebody drinks enough over a long enough period of time, they will eventually destroy their liver. It's a long process. The liver is pretty resilient. It can rebuild itself, and it takes a lot and a long time of drinking to do this. But it is certainly an inevitable consequence for those who choose to do this. And at that point, once your liver is fully gone, you can't survive without a liver, and you're going to need a transplant. So transplants can be tricky with these people because there's the problem that you have, of course, is that if you have an alcohol addiction, you can't be transplanted if you're still drinking. So people need to get off whatever they're doing, or need to find help, or be able to prove that they're sober for a certain amount of time before they can actually even be considered a transplant candidate. Chronic toxicity, so people who drink alcohol a lot. Neurologic toxicity is a big. We talked about Wernicke's and Korsakoff's with vitamin B1 deficiency, so that thiamine deficiency, which is why we supplement thiamine immediately when we have an alcoholic patient. It's a quick, easy thing to do. It's cheap. And it can prevent some really severe complications long term. Cardiovascular, it's something seen. So you can end up with CHF exacerbation, stroke risk, increased hypertension risk. Reproductive risks are there too. Fetal alcohol syndrome being a major problem for pregnant women. Teratogenicity can cause impotence and infertility in both men and women as well. Okay, so with some other things we think about, maybe like the psychological components, so cravings, loss of control, physical dependence is definitely possible, and then our acute treatments. So we're looking at benzodiazepines. Haloperidol can help because there is a psychotic component to alcohol withdrawal and acute alcohol ingestion, and then some long-term treatment options. So a couple things have been studied. Naltrexone. We talked about for opioid abuse as a chronic medication. It actually is used for this as well. There's some data that supports it. And then there's another medication called disulfiram. Disulfiram actually inhibits aldehyde dehydrogenase. So when people drink alcohol, ethanol, even a small amount, it's not going to get metabolized fully, and it's going to make them feel really sick right away. It's actually just a deterrent. And the thing about it is they actually have to take it every day. It's an oral medication. It's actually kind of similar to metronidazole. Metronidazole has a disulfiram-like component to it as well. But antabuse itself, you have to take it every day. And if you don't take it, you wouldn't get the effects. If you wanted to go on like a binge, you just wouldn't take it for a day, and then you could do that with minimal effects, and you could start taking it again the next day. So it's kind of you have to have a patient who's actually willing to do this, but it is a deterrent factor. And once they take a dose of it, they are theoretically going to be under the control of that medication for a few hours at least. So at least does deter them for a certain amount of time. So this is alcohol withdrawal, time to first onset of symptoms. So usually the first day you're going to be anxiety, maybe GI side effects. Hallucinations will start, depending on how severe the symptoms are, can start within that first day to the second day. And then usually after around day 2, you're at highest risk for withdrawal seizures. So that's when your body's probably fully rid itself, it's really craving it, and that's where your central nervous system is kind of overreacting to not having that massive inhibitory chemical in its brain anymore, so you're going to get an overexcitatory response causing your seizures. And then after a few days, delirium tremens is something that can occur. It doesn't happen in everyone, but this is where you might see some honestly like psychosis-like effects, where you see hallucinations, agitation. So that's where your medications like haloperidol can be really effective. This is a copy of our inpatient alcohol withdrawal program. This is actually the old one, I think. Although actually I think the score is pretty similar. So basically what a nurse would do, this is just sort of a standard one, but they would look at these criteria. I'm not going to test you on any of this, so don't worry about it. But if you want to figure out what stuff they're looking at here, you can see anxiety. So there's scores there, and there's descriptions of what the score would be. Diaphoresis, tremors. Some of these things are really obvious to see. Other ones would be a bit more subjective. Agitation, hallucinations, and then they give them a total score. So the nurse would assess all this stuff on a regular basis for patients at risk for alcohol withdrawal. They'd give them a score, and depending on their score, they would get certain amount of medication. So this was our old one, again using lorazepam. We switched to diazepam in a different protocol, but the point is the same. It's the same type of process. So in the first 2 hours, assess the score. If it's greater than 10, you're going to give a certain number milligrams. You're going to keep giving milligrams until your score gets to a point where it's non-existent anymore. So the idea behind this is that you're providing benzos as needed and up to a scheduled basis. We've had, and you might think, well, don't you get people who are on tons of benzodiazepine? Yes, we've had people on hundreds of milligrams of various benzodiazepines. And usually these patients are in their ICUs, but eventually once they get medically cleared to the point where they're just on a lot of benzodiazepine, they'll end up having to figure out a taper protocol. So this happens a lot with alcoholic patients. They go into these massive they have this huge withdrawal risk because they've been drinking massive amounts of alcohol. They get on tons of benzodiazepines because they have so many of these symptoms going on all the time that they're meeting the criteria. And we don't want them to have a seizure. We don't want them to be hallucinating. We want them to be as comfortable and as safe as possible. So they end up on a lot of benzodiazepines. But the problem with that is you have to taper that really, really slowly, and it can be hard a lot of times. So you have a person who might be in the hospital for a long period of time trying to get the alcohol withdrawal under control, and then also the consequences of using those benzodiazepines. So definitely not a pretty picture here, but it is, like, based on the literature, one of the best ways to do it. So it's one of the safest ways to do it, but certainly an inpatient process, not something you'd try at all on the outpatient world. So, all right, that's all I've got for that. As far as questions on alcohol, I'm going to ask you about benzodiazepines for withdrawal. I might ask you about like antabuse. And maybe just some general kind of questions about alcohol's mechanism and some of the effects that it might cause with withdrawal or chronic alcohol abuse. So, but that's about it. So these slides, again, a lot of this is just kind of FYI stuff, not necessarily testable material.